good to be here. So we divided up our topics between Jeff and I to be able to kind of break it down a little bit on the different types of surgeries that are done and kind of what to assess the patients post-operatively when they're on the floor based on their surgery. So I got the token of doing lumbar surgery. Let's see here. So with the lumbar spine, the important thing, I think, if you realize some of the anatomy, it helps you understand why you're doing an exam on patients post-operatively as far as their neurological assessments. In the lumbar spine, there's 5 vertebrae. Then there's the sacrum, which is usually incorporated kind of in the lumbar spine when it comes to surgical treatment. Each of them are separated by a disc. Then you have 5 pairs of nerve roots at each. So you have a pair of nerve roots that comes out at each level, and then you have your S1 nerve roots that come out right above your sacrum. And then your spinal cord terminates actually at the upper lumbar spine. And I think that's a misconception that a lot of people don't understand. They think, oh, I've got a back problem, my spinal cord's being compressed. You don't have a spinal cord down in your lower lumbar spine. Okay? So that's an important part of when we assess patients. If they had a lumbar surgery and they're telling you that they can't move their legs, unless they've got surgery up higher, that would be a very, very uncommon thing to happen. Okay, because most of the things in the lumbar spine are divided into individual roots that come out, and this is, you can kind of see here on this diagram. So your spinal cord's ending up higher, up here. They show coming down, and then your spinal cord stops. So after that, you have individual nerve roots that come down that are called the cauda equina, or the horse's tail, is why they call it that. Looks similar. And then at each level, those nerve roots come out. So you have roots that come out at L2-3, L3-4, 4-5, 5-1, and each set of those roots do different things to the legs. So they can provide sensation, they can provide motor function, and so that's how each one of those nerve roots work. When surgery is done on the lumbar spine, if you know what levels they're being operated on, or if it's just one level, it kind of gives you some insight on, how much involvement, how many nerve roots could be affected if there was a problem. So it does help when you hear somebody had an L4-5 discectomy. Well, most likely it's only one level. Most likely it's only 1 or 2 nerve roots that were involved. Whereas if somebody had an L1 to S1 decompression, then they had that whole area worked on where there's multiple nerve roots that are exposed and have potential risk for having a problem afterwards. And you look at the diagram here on the one side. So you have, this is the level at the disc. So here's your disc here. Around around the nerve roots is a sac called the dura, which is what we refer to as kind of a balloon. We tell patients it holds in your nerves, it holds in your spinal fluid. So that's that sac, and each of those nerves just kind of float in that fluid. And then you have fat around it, and at each segment, then you have a nerve that comes out and goes off to the side and goes off into your leg. Okay, so when you're operating on the spine, from the back part of your spine, you're commonly going through the bone back here, which is the lamina here. Sometimes the spinous process is removed to be able to take the pressure off the nerves, because that's the goal of most of the surgeries, is to remove compression on the nerves. And as you can see, there's only certain nerves and certain points that are usually involved, but you can also see how other complications can happen, such as a dural tear or a spinal fluid leak, just by knowing the anatomy and where things are. Okay? Wrong one. All right, so lumbar examination. I want to give credit to our model here, who's sitting next to me. I mean, he's got some great talents, but can your patients do this? So that's the first part of the lumbar assessment. And so Jeff can go in and show them how it's done, and he's very talented. So when it comes to doing your exam with the lumbar spine, the main thing that you want to focus on is the motor exam. So you always walk in the room. If you follow any of us around, what are we doing? We're having patients move their feet, push down, pull up, lift their leg off the bed, pull their knee towards them. So that's pretty much the motor exam that you need in the legs on a neurological patient. So you have your dorsal and plantar flexion. So if they're able to push down, that's a different nerve root. If they're able to pull up, that's a combination of two nerve roots between L5 and L4. If they're able to straighten up their quadriceps, that's predominantly L4, a little bit of L3, and then the raising up of their leg, which is their psoas, which is L3, L2. So you're able to assess each of the nerve roots based on them doing those motions. Okay, so push down with your feet, pull up with your feet, raise your leg off the bed, and then pull your knee up. So if you've got that as far as the legs are concerned on somebody that's post-surgical from a lumbar spine, that's the key. And that's the most important information we care about. If you call us and tell us, well, the patient says they have pain in their leg, it's like, well, first thing we're going to say, can they move them? Is there, do they have good strength? Because that's how we assess if there's something more significant going on, is if they start to lose strength. Then you also have your dermatomes of the spine, which this gives us feedback on which nerves are involved, or same as for each of you. So if they have numbness on the side of the foot, on the pinky side of it, then that's the S1 nerve that's involved. So if somebody says they're numb out there, which is a common symptom that people have prior to surgery, and a lot of times that's something that doesn't just go away with surgery. So we don't stress as much about the sensation part of it when it comes to the legs, because a lot of that takes time to get better and doesn't just get better after surgery. And sometimes people, when you work around their nerves, they have more numbness afterwards just from manipulating the nerves, just from having blood products around the nerves, and so that can also cause some more numbness and tingling. Now, if you have somebody that says to you, I have numbness and tingling in both my legs, my groin region, everywhere, well, that sounds more of a problem. And we'll discuss that in a second as one of the potential problems that can present. All right, so we're going to go through a couple of the surgeries and look at how the access is done, and then that will be able to help you know what the assessments are important. So for a lumbar discectomy, all you're basically doing in most cases is making a very small incision in the back, and you remove just a tiny hole up through the bone of the lamina to be able to get to where the disc is herniated, and that's where they're kind of showing you here in this picture, that you work around the nerve root here, so you usually retract the nerve to get to the disc, and you take out the disc, okay? But what you can see you're working on the nerve root. You're also working around that dura, which holds in the other nerve roots and your spinal fluid. So after surgery, what are you looking for? You're looking, what's their strength, okay? If you're doing an L4-5 and the patient preoperatively can move their feet fine, but now they can't pull their foot up, well, there's more weakness there. That's concerning for that nerve root that they just had surgery around, okay? If they have headaches afterwards, why could that happen? Well, you could have a small spinal fluid leak right here from the dura, and sometimes you know that at the time of surgery. Sometimes you don't see it because it could be such a pinpoint little hole. So if somebody's saying, when I sit up, I get a headache, but if I lay down, I get better, that's what we call a positional headache. Then you have to kind of follow that to see if that stays true to form. If that's happening, then that would be a possible concern for a spinal fluid leak. And then the other thing that we talked about was if somebody got a big blood clot that pushed in on this whole space here post-surgery, then they could get compression on all those nerve roots in that area, which those nerve roots that are left in the sac down here are mainly nerve roots that go to your groin region, your bowel, your bladder. So if somebody's saying, I have horrible pain in both my legs post-surgery, if they're, for some people, if they don't have a catheter or whatever, they're peeing on themselves, they feel numb in their groin, we call it saddle anesthesias, so you touch them in the groin, they really can't feel it, then that would be, what we call cauda equina syndrome. So that can happen from a blood clot after surgery. Now, most of the time when we see this, it's something that somebody presents with because they had a big disc herniation here that pushed into this canal and closes off the canal acutely or all of a sudden, then that's how the patients will present to the ER with some of those symptoms. But if you saw it on the floor, that would be probably your biggest red flag. If they were saying, look, I'm numb in my groin, can't move both my legs very well. They can usually move them some, and then loss of bowel or bladder function. All right, so this is the posterior lumbar fusion, which you hear people say PLIFs or T-lifts or whatever. They're going through the same space as the microdiscectomies and laminectomies. So they're going right through the back here, where the lamina is here, and they're working around that sac to be able to fuse the spine up here up front. Okay, but the risks are going to be the same as for a laminectomy or for a microdiscectomy because they're working in the same area. Do they have weakness in their leg again? Do they have a potential blood clot? Are they leaking fluids from their backs and so forth? So those are things that you watch the same for a posterior lumbar fusion, which is the T-lift or the PLIF. The concerns would be the same. So here's a couple of the things that you look at. Weakness, on their exam. Now, some patients after surgery, because their back hurts, they don't want to lift their leg all the way up, okay, because it hurts their back. So you have to kind of encourage them, say, hey, raise your leg up. I know it hurts, but just give me effort with it. And if they can get their leg up and resist you, then they're okay. So you have to kind of assess, is it really that they can't move their leg, or is it because they hurt? The other thing I just mentioned was also checking the incision. If they're draining fluid from their incision, they have a big bulge in their back. Is the drainage clear to suggest like spinal fluid or very, very thin? Those would be something to be concerned about. If they have a drain in their back, is the drain pulling out thin fluid or clear fluid, which would be suggestive of spinal fluid? Is it not working, the drain, but they're developing a kind of a hematoma in their back, but they have a drain in? Who here knows how to strip a drain? Okay, so to strip a drain is you basically start where it exits the back, you pinch the one end, and you just slide it down, so you slide the blood through it out to the bulb because the bulb keeps the constant pressure on it. Sometimes if there's a clot in the drain, when you strip it, it will pull the clot through and then allow the drain to start the suction again. So if somebody's developing, kind of a clot in their back, but it's not coming out through the drain, then if you strip the drain, then a lot of times that will break up that clot. If it's pulling out spinal fluid, what looks clear to you, or very, very thin, there's a way you can test it, is you can put a little bit on a paper towel, and if it makes like a bullseye on the paper towel, then that's suggestive of that it's spinal fluid. Okay, then that's something that you'd want to notify the provider who's on call. They'll probably tell you just to take the pressure off the drain, okay, then to take the suction off of it. Then the last thing too there is gait. When you get them up and walk, can they walk? Do their legs support themselves? Those are also some red flags that you can look for when seeing those patients. All right, next one is the anterior lumbar fusion, which here they also call them for some lateral A-lift or O-lift procedure. So this is the incision that they either have on their groin here or on their side, or some of them are in the midline. Okay, so there are different spots where these incisions can be, but they're going around your peritoneum or your abdominal contents to get to the spine, and then we are working between the greater vessels here. They come down, so your iliac veins, iliac arteries, sometimes right at the aorta. To do the surgery, we're working between those structures. So those are cases that Dr. Medley assisted with. So if you know that Dr. Medley assisted with the case, then most likely they had an anterior approach of some kind. Now, again, thinking about how the procedure was done, you can think of the potential complications. So what would be a potential complication of working in this area? The vessels, right? So that's one of the biggest complications, is the bleeding. So if somebody's all of a sudden, up on the floor, they have, excruciating abdominal pain, they're hypotensive, as soon as they stand, they faint or pass out. Those are signs that they could be losing blood in the abdomen, because he usually doesn't leave a drain in, so you're not going to know if there's a lot of blood coming out either. So if there was something that did start to bleed, that's something you'd be able to catch on and say, look, this person's really hypotensive. They're still getting fluids, but they feel faint every time they sit up. They said their belly really hurts, not just at the incision, but they kind of hurt all over. It's kind of diffuse tenderness usually. Sometimes they'll complain of pain going towards their scapula if they really start to get more and more blood. Sometimes when they sit up, they'll get what's called a vagal response. So you have your vagus nerve there. That will actually cause them to pass out just by sitting up. So it's not necessarily always related to the blood pressure dropping, but you can see that. So any of those kind of warning signs that you're seeing with the patient when you're starting to move them or get them up, or those complaints, then definitely you want to check their H&H to see if that's an issue. And if it has dropped considerably, then a lot of times we'll check a scan to see if there's anything more. But that's kind of the start. The second part is an ileus. So because of a lot of these are now done through smaller incisions, the ileiuses are less common that we see them. But that's one thing that we need help monitoring and helping patients understand that's why they we monitor their bowel sounds. We ask them if they're passing gas. We ask them if they're sick to their stomach. All that is something to monitor. Definitely several days after surgery, not as much the first day, because everybody's a little bit slowed up the first day following surgery. But if they've been in the hospital for a couple days, definitely keep an eye on that. Definitely if a patient feels sick and they don't have very good bowel sounds, don't encourage them not to eat instead of to eat. To tell them to kind of listen to their body. Little star point here, because this is a call that I get every week that I'd love everybody to pay attention to. Dr. Medley and Darren do not want their patient on a regular diet within 24 hours of their surgery. So if you want to call somebody and fuss, I like to call Darren. Okay, so that's my little tip to you, because we get calls on that all the time, and patients will fuss at us that they want to eat their regular food and stuff like that, but that's not our call, because they want them on full liquids at the most for the first 24 hours. That's just kind of their protocol. They're sticking to it. And if I change them, I'll hear it. So I'll give you a hint. I'm not going to change it. So you guys can help with that. Encourage patients to understand that. Say, look, the reason they do this is because they want to kind of work you back into your diet, make sure you're okay, make sure you're not throwing up right after you had surgery, and they'll let you progress it, tomorrow afternoon, But so, giving the patient that counsel really helps, kind of solidify what we're trying to teach them. The other procedure that's done for the lumbar spine that's pretty common is the Xlift. So the Xlift is done differently than the O-lift or the lateral A-lift. It's an incision that's done right above the iliac crest on the side. Okay. So in this procedure, they're going through the psoas muscle here on the side of the spine to be able to access the disc space, to be able to do the fusion. Benefits of that is you're not working around the nerve roots in the back. But you are going through the psoas, which has nerves in it. So we have monitoring systems that help us monitor those nerves going through the psoas. The things that you want to watch on these patients is the biggest concern is leg weakness. Okay, with that, and the leg's going to be weak in the proximal leg, so up in the upper leg. Again, when they pull up their psoas, because we work through the psoas, it's going to hurt. So they're going to feel discomfort when they do that. That's normal. But there's a difference between them saying, I can't pull it up, or it hurts. So you have to give them that encouragement to say, keep trying, pull it up, pull it up. The biggest risk after this is not psoas weakness, but it's actually quadriceps weakness. So it's actually straightening the leg out. Okay. So if somebody tells you they can't pull their leg up with their psoas, that's usually just because of irritation. The biggest risk is, like I said, if somebody really can't raise their leg up off the bed when you lift it up at the thigh and they can't straighten their heel up, that's the biggest concern that you can see with Xlift patients. It's not real common that we've seen it here, but in the literature, it can be up to 1% of patients can potentially have that risk. Now, in most of those patients, within 3 to 6 months, it gets better, but that's something to keep an eye on, is the leg extension or the quadriceps after the Xlift. Okay. Any questions? That's my family. Besides one. One of them's missing. My son just got married this summer. So, this is the crew there. All right.